but we're going to try to focus on the subtleties of the case and what you should be thinking of as you go through and read the description. And so if you guys have any questions throughout, go ahead and put them in the chat, or you can try to chime in. For the people that are watching on YouTube, we're going to be transferring over the comments, so feel free to comment. And if I don't get to your question, you can put it in again. But also, if at the end we don't have enough time to go over everything, just put the information in the stream, and I will in your classroom stream, and I can answer it there. All right. So I will be calling on you throughout the case, and so if you don't have your mic ready, or if it's not working, it's okay. Just let me know in the chat, and I'll move on. All right. So let's get started. So we have a 78-year-old with progressive chest pain and shortness of breath over the last 1 to 2 weeks. She's a little confused. She can tell you who she is, but she can tell you the date, but she can't tell you where she is or why she's there. Her daughter's present, and she's helping you with some of the history taking. So about a week ago, or 2 weeks ago, she felt sick. So she had a sore throat, congestion, and a slight cough. And so knowing that, Dr. Ho, what would you be thinking of?
The sore throat, congestion, and slight cough would concern me about maybe a prior infection. Her shortness of breath, I would ask her, when did it start? What makes it better or worse?
Okay. So her shortness of breath, it's been there for about the last week, and what makes it better or worse, she's not really active as much, and she can't really tell you that. She feels more tired than anything. And then I'm sorry, you said that the sore throat, congestion, slight cough would make you think of what?
An infection.
An infection. Okay. So what kind of infection are you thinking of?
Maybe a viral infection.
Okay. Would it be, does this sound like an upper respiratory infection or lower respiratory infection?
I'm not too sure, but my guess would be an upper.
Mm-hmm. So when we talk about upper versus lower, basically anything in the lungs is going to be lower, and then your throat, your nose, and your ears, it's going to all be upper. And so for the most part, upper respiratory infections are usually viral, and so that's a good thought. Those are good thoughts. So she got better, but then her cough lingered. 1 week ago, she began feeling more weak and was complaining of chest discomfort. She would normally walk around the block, but she doesn't want to because she's telling her daughter she felt sleepy. Now, Dr. Sabla, why am I telling you that she would usually walk around the block and now she doesn't want to because she's sleepy?
So you can compare like how active she was before and how she is now.
Okay.
And like her mental state. So, yeah.
Okay. And so, what if I told you that she doesn't want to walk around anymore because she's feeling more short of breath? What would that make you think of?
That would make me think of like the lungs and if there were like respiratory issues, but sleepy is like a little bit different. Okay. So first I thought it might be like due to her dementia, but since it just started, it has to be something related to the new infection that just came.
Perfect. So this is a new, these are new symptoms for her. So this sounds like it's something more acute is what you're trying to say, right? Okay.
Yeah.
And so you're right. If she was complaining of more shortness of breath when she walks, that's important to know because that helps us to differentiate between a possibly infectious etiology, a lung problem, or a heart problem. If I told you that she was having chest pain when she was walking, what would that make you think of?
So that could either be her lungs or her heart, but since it's getting worse with activity, it would most likely be her lungs because when she's breathing, it's getting worse.
So if it was chest pain, it would most likely be her heart because if you're exercising, your heart's going to be working harder, and so if the vessels are narrowed and it's narrowed to the point where you're not getting good enough blood supply to that part of the heart, you're going to end up having some type of ischemia. You're going to have some type of heart injury to that area that is cut off. And so as you walk, as you exercise, as your heart starts to work a little bit harder, you're going to have a harder time. You're going to have a harder time actually doing your exercise. Is everybody able to hear me? I see Tima wasn't able to hear me. I'm assuming yes, because you guys are answering. Okay. Okay, so 6 days ago, she was up at night and confused, but could not go to sleep because of the cough. Why would I focus on the confusion, Dr. Kinder? Okay, let's go to Dr. Avalos. What does the confusion mean in this case? Yeah, Dr. Kinder, I can't hear you.
I would say that it would make me worried about dementia or any mental problems that she could have that could be prior conditions.
Yes. Yeah, so we know later on that she has a history of dementia, but if the daughter is telling you that she is more confused, would this be a problem because of her dementia, or would there something else be going on?
I would say there could be something else going on that could worsen it.
Yeah, so when you have a baseline dementia, it's always important to know what the patient's baseline is. So if at baseline the patient really can't tell you, where she is or why she's there, well then this isn't really different from her baseline. But if her daughter's saying, yeah, she's more confused, she's usually able to do everything that she needs to do to survive by herself, and now she can't, well, that's a new change in baseline. And so a lot of times with patients with dementia, it's really important to figure out what their baseline is. And knowing changes in their baseline mental status is very helpful to picking like acute processes out. So if you have somebody with progressive dementia, it's not going to just all of a sudden turn into something new where she is going to be disoriented and confused. That process is very gradual. Versus if you have a infection or a stroke or something like that, you're going to have an acute change and you're going to be able to see it. So, good. Okay. So as she continued to cough, her chest pain worsened, and her cough was non-productive. So Dr. Yamaoka, Marie Yamaoka, can you explain what we were talking about when we say that her chest bursting with cough?
Yeah, so if the chest pain is worsening due to the cough, we could suspect a pleural inflammation or inflammation of the cartilage between the ribs and the sternum.
Perfect. So we're looking at all the different causes within the thoracic cavity. So that's the pleural lining. You can also think of the pericardium, and because whenever you're breathing and you have pain because of the pericardial inflammation, well, when you cough, you're also moving that pleura and that pericardium, so you're going to have that pain as well. And then I like what you said with the cartilage. So can you explain that a little bit more? Why is it that we'll have pain when we're coughing?
So I guess when you cough, that the cartilage between the ribs and the sternum will basically move and be like under pressure, I guess, maybe.
It's kind of like when you work out and you're not used to working out, and you get really sore. It's similar to that because your ribs and the muscles between your ribs are used to breathing normally, right? You're not really exerting yourself. But when you're coughing, you're forcefully pushing all that, forcefully contracting those muscles to really push that air out. So whatever is in your lungs can get out. And so if you do that over and over and over again, you're going to get sore. It's going to become inflamed. And so, yeah. So do you know the name of that syndrome, I guess?
I'm not sure at the top of my head.
It's okay. It's costochondritis. That's what we call basically the inflammation of that cartilage between the ribs and the sternum. Okay. So the chest pain was located in the right lower chest, peristernally, and radiates to the right arm. And so, Dr. Halal, if we are talking about right lower chest pain that radiates to the right arm, what are you thinking of?
So I'm thinking about the radiation, how the pain travels to the right arm, and it says that there's no rash, so that kind of like relieves me a little bit, but I'm still worried about the radiation, how it travels to the right arm. The heart is to the left side of the body, so I'm not thinking right away about heart conditions, but I'm worried about maybe a pneumothorax because of it's like collapsed lung, so I'm worried about the pain radiating to the right arm.
Okay, so you mentioned a pneumothorax, and so let's talk about a pneumothorax. So with a pneumothorax, a lot of times you're gonna have pain when you breathe, and she's saying she's having pain when she coughs, but a lot of times you're gonna have a more sudden onset type of pain, right? So for hers is a little bit more gradual. That's a very good thought though, because you definitely don't want to miss a pneumothorax. And then you mentioned that heart pain is usually on the left side, right?
Yeah.
So if it were cardiac pain, the typical findings are going to be left-sided or substernal chest pain that feels like a crushing weight on you, like an elephant sitting on your chest. And so, but she's 78 and she's female. So is that hold true for her, like 100%?
Probably not as much because she does have a history of dementia, so I'm not sure about that one.
That's okay.
If that's true. Yeah.
Yeah. So it's not so much because of the dementia; it's because of the way we classify chest pain initially, and the studies we ran on chest pain. And so, typical chest pain is not typical for everybody. So in elderly patients and in women, they can have jaw pain, and that can be a heart attack. They can have abdominal pain, that can be a heart attack. So you always want to keep an open mind, especially because we know later on that she has a history of coronary artery disease. Okay, so Dr. Martis, if I am saying that her pain is radiating to her right shoulder, is there anything else in the chest that could be causing her to have this pain?
I was thinking that it was closer to a pulmonary embolism because taking into account all the various things, the altered mental state, her coughing, her having these infections and stuff like that. The only issue would be that it's not sudden sporadic chest pain, it's more of an onset. It's more of a, did you hear what I said?
Yeah, okay, can you repeat it? Sorry.
Sure, no problem. I was thinking it was closer to a pulmonary embolism because of the altered mental status that we were dealing with. Because like we were talking about, even though she does have dementia, her daughter is mentioning that she seems to be a little bit more confused than usual. And as we talked about in the videos and stuff like that, it seems to be that the pain can radiate into extremities and other sorts of areas. But like you said, because the pain isn't sudden, that was my only issue with really focusing in on that. But apart from that, a lot of the things seem to line up with a pulmonary embolism, just without the pain. And I guess the side switching, again, like you said, can do with her not being a typical white male patient that we've used for studies. So.
Yeah. So like you said, with the pulmonary embolism, it's going to be more sudden onset. Dr. Yamaoka is mentioning something about the phrenic nerve. Do you know anything about that why maybe that would cause right shoulder pain?
The phrenic nerve connects to the kidneys, correct?
No. So it innervates the diaphragm. So the phrenic nerve comes from the cervical spine, and it travels down and basically controls the way the diaphragm works. And so those same nerve roots actually go down to the brachial plexus and into the right shoulder. And so this is all referred pain. So if you have pain or irritation of the diaphragm, you're going to have referred pain to the shoulder. Just like if somebody were to be, so if a male were to be hit in the testicles, well, that the origin of the testicles are in the abdomen, and so you're going to feel the pain more in the abdomen, not so much in the testicles. Does that make sense?
Is it similar to how the esophagus and chest share nerves? So if we have an esophageal pain, we might feel chest pain if there's an esophagus problem?
Kind of, because it's more so because of the anatomy. So the esophagus runs right behind the heart, and so if you're having esophageal pain, well, it's right behind where the heart lies, and so you will have that pain because of location, not so much of the referred type of pain.
Okay.
Yeah, and so what we usually say, like the mnemonic we use is C345 keeps the diaphragm alive. So that's our way of like remembering that the diaphragm works with those nerve roots. And so yeah, good. All right, so let me see. So that morning, the daughter states that she appears more confused and she refused to eat. And so, Dr. Herrera, why is it that her refusal to eat is important?
If she's refusing to eat, then that's basically, it's also a change in behavior for her, and she's losing like her sources of nutrition, which can cause her condition to worsen. I was just gonna say, like, some of the numbers in her blood test, for example, can change as a result of that as well.
Yeah, potentially, yeah. So, so her refusal to eat, like you said, is another clue that there's a change in baseline. And so, knowing that, the last few days she was still eating, but now this morning she doesn't want to eat and she's more confused, that's an acute drop. And so a lot of us, especially younger people, have a good reserve, so they're able to compensate for illnesses. So they'll be doing better, they'll be doing okay, and then suddenly they'll drop. And especially in pediatrics, kids are very resilient. And so if a kid comes in and they look okay, but their labs look a little funky and maybe they're a little tachycardic, you better be very careful with that patient, because they can easily drop and become more ill very quickly. And so it's important to know kind of these baselines and ways to distinguish whether or not patients are doing well or not. And so the refusal to eat is another indication that she's probably not doing so good. Okay. So, Dr. PJ, I told you, so I say that she denies nausea, vomiting, chills, abdominal pain, hemoptysis, loss of consciousness, palpitations, and anosmia. So, what in those statements stood out for you?
The one that stood out to me the most was the denial of the hemoptysis, because normally what hemoptysis is like coughing up blood or any mucus, so that can level out any type of serious infection. Well, not serious infections, but any infections that can be related to like viral or bacterial. And then the loss of smell means that like she doesn't have any infections related to her nose and stuff. Denying the chills means that there's not that there, even though there is a fever due to her elevated temperature, it doesn't mean that it's too much to the point where like she's getting chills. And then abdominal pain means there's no inflammation happening in the abdominal, well, sorry, I can't say the word, cavity. And then palpitations could possibly rule out any irregular heart abnormalities.
Okay, good. So let's take hemoptysis first. So you said that it's potentially a bad infection. Is there any type of infection that you know of that traditionally causes coughing up blood?
No, not really.
Okay, I think so. If you're not sure, sometimes looking at the chat can help.
Okay, so the chat says TB.
Yeah. So tuberculosis is very traditionally causes coughing up blood, and so
Right.
if anybody comes in and says, "Hey, I am coughing up blood," well, you better be very careful with TB,
Right.
and you need to rule that out. So somebody on YouTube is saying, "Does that rule out TB?" It doesn't. It doesn't rule out TB entirely, because there's going to be you can also have TB that doesn't cause hemoptysis. You can have TB in other parts of your body as well. What about cancer? Do you know how cancer would potentially cause you to cough up blood?
No, I don't.
Okay. So with cancer, if we think about it just logically, so cancer is an abnormal growth of cells, right? That divide very quickly, right? And so it starts to invade the lung parenchyma, so the actual lung tissue itself. And once it starts to invade there, it recruits more vessels to it, so it can grow faster. But at the same time, it's disrupting the vessels around it, and so you start to bleed inside of your airways, and that's it. And blood is an irritant, and so you'll start to cough that up. And so that's how it basically causes you to cough up blood. Perfect. Dr. Melot, is that how you say your name? Sorry if I mispronounced your names.
Oh, that's okay. That's how you say it.
Okay. Can you you're asking if pulmonary embolism can also cause you to cough up blood, right?
Yeah.
Okay, so why would that cause you to cough up blood?
I was thinking maybe if it was in one of the smaller vessels, maybe it doesn't cause complete obstruction of the lung blood, but maybe, I'm not sure. I think I heard it in the video that it could.
Yeah, so it can. It can. I've actually never seen it, but it can cause that. And so I just might not have seen enough of severe pulmonary embolisms. But what happens is that it cuts off that artery, right? And so as the pulmonary arteries go to the lungs, you cut that off, and so the blood supply to that territory of the lung is now cut off completely. And so you have lung tissue death. And so as the tissue dies, you can start bleeding into the airways, making you cough up blood. So it's all kind of that destruction of lung tissue. But good job. So and then Dr. Herrera is saying, can pneumonia also be another cause of coughing up blood? I don't typically see pneumonia causing hemoptysis as much, unless it's a more severe pneumonia, like due to like tuberculosis. Yeah, I don't think I've ever seen just a regular community-acquired pneumonia causing hemoptysis, but I can look that up too. Okay. And then so the second part of that was the anosmia. So Dr. Sanchez, why did I mention the anosmia?
So I believe that anosmia, I kind of got confused with it. So I was kind of thinking it was either having to do something with her abdominal like pain, or it could have been something with her sleeping.
So anosmia is basically the lack of smell, right? And so so with anosmia, have you heard of anything going on right now that can cause you to have a decrease in smell?
Not going on right now. Maybe a buildup of like bacteria, probably.
What about the reason why we're all socially distancing?
Like face mask and like, I'm guessing like not enough CO2.
So the coronavirus can cause anosmia. So
Okay.
Recently, out of all the patients that I've seen that had anosmia, they've all had COVID. And so I actually included it in this case because I wanted you guys to be aware of that. If you guys are volunteering anywhere with patients, if anybody tells you that they have a lack of smell, make sure that you have proper protection. But good. So we'll stay with you on that same thought. So she lives at home with her daughter and son-in-law, and then I tell you that the son-in-law is still working, and he's required to go to the office to work. And so why would I tell you that? And that he does not work in healthcare. Dr. Sanchez?
Yeah, sorry, my connection cut off for the moment.
It's okay.
Okay. I didn't get the question.
Oh, okay. So,
Yeah.
I told you that the son-in-law is working along with the daughter, and the son-in-law has to go to work. It has to go to the office. So, is there a reason why I would mention that in this case?
So I'm guessing that you would mention that so that we can be able to see like her home state, anybody, coming in and out of the house where she lives at, and also to take better observation of her if we have to and admit her into hospital care.
Yeah. So the knowing who's coming in and out of the house is important, especially because of COVID. He might have been exposed, and he can bring that in. So she is a little bit at risk. And then the other thing that you're saying is that to know what her home life situation is. So if she's by herself a lot of the time and she has dementia, that could be an issue, right? Because what can happen? Like if she's by herself, she has dementia, she's taking her own medications.
She can forget things easily, have confusion with certain things, not remember anything. So it can be difficult for her to take care of herself.
Yeah.
After her own care.
Yeah, perfect. And so, Dr. Julietta, you're saying that if she's responsible for her own medication intake, so what are you thinking about there? Dr. Julietta? Okay. So, if she's not able, if she's responsible for her own medications, she might, and she has dementia and it's progressive. Well, she might forget to take her medicine, or she might forget that she had taken it already. That's okay. And so that's something really important to know about, and know if she's been really consistent with taking her meds, if she's responsible for that. And so, Dr. Tuska, is there anything in her medications that you'd be worried about if she took an extra dose of?
I think potentially one of her diabetes medications can cause confusion as well as like increased loss of appetite. I didn't really do much research on the side effects, so I'm not really sure.
It's okay. So let's think about it just logically then. If she's taking diabetes medications, what is that going to do to your blood sugar?
It's going to lower it, and that could lower it to a dangerous level.
Perfect. So just logically, if she takes too much of her diabetes medications, well, she can become hypoglycemic to the point where she's going to be more confused. Would you expect that to be something that comes on gradually, or something that's more sudden?
Usually something that's more sudden, because glucose levels can change day by day, but given her labs and her glucose levels are normal, that's probably not the case.
Yeah. And so Dr. Yamanka is saying that we know that she takes glipizide, which can cause confusion from forgetting or overdosing. So yeah, so you guys are both correct. And the one I'd be more worried about is glipizide. Okay. So let me see here, Dr. Mustafa. I give you her vitals when she comes into the ER. So her blood pressure is 158/93, her heart rate's 110, respiratory rate's 24, temperature is 100.5, and O2 sats 93 on room air. Can you interpret those vitals for me?
Her blood pressure and heart rate are both high. I think her respiratory rate is also high for her age. Her temperature is definitely higher than normal because she had a slight fever. Her O2 stats are kind of low. I think they should be a little bit higher too.
Yeah, and so so she has a high heart rate. She has a high respiratory rate. Her temperature is high. Her O2 sats low. Her blood pressure is a little on the higher side. We don't mention if she took her blood pressure medications or anything like that. So, so good. So with all of those vitals, is there anything that you that comes to mind? Is there any disease process that might come to mind?
What I'm thinking is that since her O2 sats are low, she's not able to get enough oxygen in, and her heart rate is higher, so her heart's working a lot harder too.
Yeah, so so her heart is working harder, and we know that through the tachycardia. Dr. Yamaoka is saying SIRS. So do you know what systemic inflammatory response syndrome is? It's okay if you don't.
No, I do not.
Isn't it?
Okay, Dr. Yamaoka, do you know?
Isn't it like a inflammation in the the systemic, I guess, path?
Yeah, so it's system-wide inflammation, and so a lot of times when we have some inflammatory process going on and it causes inflammation throughout the body, you're gonna have vitals like this, and so it's an actual there's a specific criteria to it. So you have to have an elevated heart rate. You have to have an elevated. So let me back up. You have to the criteria is they have to have 2 out of the 4. So either elevated heart rate, elevated respiratory rate, elevated temperature, and an elevated white blood cell count. And so, let me see here. I am going to mispronounce your name, so I apologize. So Dr. Subastika?
Yeah, Subastika.
Subastika, thank you. Tell me what you're saying about sepsis.
Yeah, so I was thinking that the fact that there's so many stats that are elevated, usually in sepsis, I think it's like the O2 stats are down, the BP is high, the heart rate is high, and the temperature is high. I'm not too sure about the temperature, but then the other symptoms do seem indicative of sepsis.
So yes, so sepsis is SIRS, so the systemic inflammatory response syndrome, but it's SIRS with a source. And so if somebody comes in with these vitals and everything like that, and we don't know what's causing it, that's SIRS. We can't say it's sepsis because there is no source. But as soon as we know, like let's say somebody comes in with urinary issues and it looks like she has a bladder infection and she has these vitals, well, we can say she's septic because of a UTI. Does that make sense?
Yeah, that does. Okay.
Yeah. So so perfect. Let me just review some of these questions because I think I missed some. So it's, Dr. Martis asked if she was overdosing on her glipizide, was that why she might be tired? And yeah, it can definitely make her tired. Dr. Brown is asking, would you say her blood pressure is high even though she has hypertension? And so yes, I would, because even though she's normally high without medications, the whole point of the medications is to bring her blood pressure down to a normal value. So if it is still high, we would say it's still high, but we would say it's uncontrolled hypertension. Hypoxia can lead to altered mental status, which is true. Okay, I think I caught up. All right, so so let's go to Dr. Rodriguez. Is there anything in her? So tell me one thing in her physical exam that stands out to you. Okay, let's go to Dr. Baker then.
I think that the tacky mucous membranes, something that stands out. It
Okay.
could be dehydrated.
Yeah, so that tells us that she might be dehydrated. Okay, and so we'll jump to the lab super quick because you mentioned dehydration. Is there anything in the labs that point to dehydration as well?
I think I'm not sure.
That's okay. So the creatinine being elevated can point us to her being dehydrated, and we'll get to that in a bit. Okay, so good. Dr. Chima, anything else pop out to you in the physical exam?
It says that she can still move all extremities, so maybe it's not necessarily related to like motor function.
Good. So okay, so that's a good point. The negatives are also very, very important. If you have somebody that's acutely altered and you for whatever reason are thinking maybe this is a stroke, knowing that she has full function in her upper and lower extremities tells us that it's probably not a stroke. So that's actually a very good point. You always, when you look through cases, always pay attention to the negatives as well because that'll help you out. Good. Let's go to Dr. Matthew. Anything else in the physical exam pop out?
It says that she has mild crackles in the right lower lung. So my thought process was kind of that indicated pericarditis because you have that friction round between the lung and the heart.
Okay. So what would you typically hear with pericarditis, though?
I'm not too sure.
I think you mentioned it. Sorry. You would hear more so that friction rub. So it would sound like that scratchy type sound. And if I were to lean forward, would that make the chest pain better or worse with breathing?
It would be better.
It would be better. So good. So the crackles aren't so much a sign of pericarditis. What it shows is more fluid. So within the alveoli, the end sac of the lungs, when you are inflating those and there's fluid or pus or anything in there, as they inflate, they create this crackly sound that really does sound like Rice Krispies. So it's more indicative of like a fluid in the lung. Good. It's Dr. Brown is saying that it's in the lower right, so it can't be pericarditis. Yes, most likely, but you'll be surprised at how chest pain can sound or feel like in different areas. So, but you're saying that it sounds. Actually, no, sorry. Let me backtrack. I was thinking more subjective. So yeah, if you hear it in the right, it's less likely that it's pericarditis. Good. Okay. Perfect. So, and then Dr. Laramia, anything else in the physical exam pop out to you? Or let me rephrase that.
Yes.
What about the tachycardia?
Tachycardic means her heart rate is elevated?
Yeah. So if she had, so what are some things that you think about with tachycardia? There's a lot, but just name a few.
Well, basically it just means that her heart is working harder, correct?
Okay. Yeah. It means that her heart's working harder. Dr. Pereira is helping you out.
Oh, it could be a PE?
Yeah. So PE, the number one thing that you see in the PE or that can suggest a PE is tachycardia. So always have a suspicion for it. Okay, good. So, Dr. Brown, can you interpret her CBC for me?
You said interpret her CBC. Yeah. So you see the white blood cell count is very high. It's supposed to be between 4 and 11,000, and she's really high. Her hemoglobin's normal, and her platelets are at the higher end, but they're still within the normal range.
Good. And so, if I've said her platelets were 500, would you be worried?
I don't know. I mean, relatively, maybe not, just because the range is so broad, and because it's only 50K above. You know, but I also don't know if that's right. Okay.
Yeah, I mean, that's a good thought. So that, I mean, if it's mildly elevated, I don't necessarily care. The other thing is that the platelet count can also be a sign of inflammation. So when it's high, it can tell us that there's some type of inflammation there.
Okay.
Okay. Good. And so you said the white blood cell count being elevated. What does that mean?
I immediately thought of infection too, also because with her elevated temperature, something viral maybe.
Okay.
But, yeah.
Okay. So let's say that this was a respiratory problem. Let's say she has pneumonia, and we start treating her with antibiotics. And she isn't getting better initially, so and it looks like she's actually getting worse. So we add on some steroids. She's let's say then after that she sounds better, she looks better, her vitals are better, but then her white count starts going up. So if a white blood cell count is a sign of infection, does that mean that she's having a worse infection?
Not necessarily. I think it could just mean her body's working harder to fight it off, but I don't know.
So potentially, yeah, but Dr. Giulietta, can you explain what you are talking about?
Okay.
Yeah, so whenever a patient has pneumonia, they were treated with steroids, and they normally don't die from the bacterial infection, or they don't get worse due to the bacterial infection. They die because of something known as acute respiratory syndrome, ARDS, I think. And that's just how your body's responding to the infection. So you can have flash pulmonary edema where your body's essentially drowning yourself, and that's prevented by giving steroids. But steroid medications are known to increase WC count.
Yeah, so the steroids can increase the white blood cell count. And so what Dr. Giulietta was saying is that when you have when you're not getting better because of like a pneumonia or some other respiratory infection, a lot of times it's because your body is overreacting to that infection, and so you create a lot of inflammation. And whenever you have inflammation, your vessels will dilate. And so as the vessels dilate, they become more leaky, and so you start spilling fluid into the pulmonary tissue, and you start basically drowning yourself because there's too much fluid in there, and so that is ARDS. And so to help control that, you would give steroids to bring down that inflammation. Okay,
but then that would subsequently increase the white blood cell count.
And that can increase the white blood cell count. Yeah, perfect. It's kind of a roundabout way of talking about that.
Yeah.
Okay. So, all right. So, Dr. Fickle, talk a little bit about her creatinine.
You mentioned earlier that it could be a sign of dehydration.
So her creatinine is 1.88, but her baseline is 1.1. So she's normally a little high. So does it matter that it's now 1.8, or is it she's just always high, so it doesn't really matter?
No, because it does matter because it's an increase over her baseline. And like we've talked about before, when things deviate from the baseline, even if the baseline is high, it's a sign of a worsening condition.
Okay, good. And so if she's a little bit higher than her baseline, that tells us that she has chronic kidney disease, but there's something on top of that that's causing an acute kidney injury as well. And so we have to look and see, what that may be. So in her case, because she has signs of dehydration, a lot of times if you're not perfusing the kidney well, if you can't put enough blood to push enough blood to the kidney, well, the kidney's going to be a little stressed and cause a little bit of an injury. So good. All right, and then let me see. Dr. Abdul Rashid, can you interpret the troponin for me?
So troponin, I think if I remember correctly, is the protein, or no, the hormone in your heart muscles. I think that's what it is. And the levels in the labs that it shows that it's above the normal levels, and that can probably explain the tachycardia, because this could explain that the heart is using is more excessive and using more force.
Yeah, so the heart is working harder, and we know she's dehydrated, so she's not perfusing her organs very well. And so you can have kind of a transient type of ischemia, which we call a demand ischemia, because her heart is working harder. And we also know that she has CAD. So in CAD, you have you already will have a decreased flow to the heart because of the narrowing of the vessels. And so if your heart is stressed, well, at that point, you're going to when it starts to work harder, you're not going to be able to push as much blood to that area, causing a little bit of stress with the heart. And so if there is any tissue damage to the heart, that can cause an elevated troponin, because troponin is an enzyme within the heart muscle itself that can spill out into your bloodstream. So, so Dr. Rodriguez, the troponin is released as cells die and lyse, so it is showing there's damage to the heart. So yeah, perfect. So if we are worried about that, and she has a history of CAD, what is the next thing you would do, Dr. Rodriguez? Let's go to Dr. Snarsky. What would you do?
I would order an EKG.
EKG. And what would you, for this patient, we know that she had sinus tachycardia, but let's say it was a heart problem. What would you see?
I know in one of the videos you mentioned that they could look like tombstones, like the elevations in it. So that could show something's wrong.
Yeah, so if you have a full-on ST segment elevation, it can show that that tombstone appearance, and so so yes, you're right, and that would be indicative of what?
Angina?
Not angina.
Or a heart, like a heart attack.
A heart attack, an MI. Yeah, exactly. And then Juliet is also saying that you can also have depressions or T-wave inversions, which are also very true. Okay. So, Dr. Girgis, let's say that you, it's okay, Serafina. So let's say you have, you get the EKG and it shows, or let's say, okay, you get the EKG, it shows ST segment elevation. What do you want to do next?
Maybe look at an X-ray.
The X-ray won't show you anything about the heart, but let's say, so like if somebody's having a really bad heart attack, which is what is happening, do you know what you would do next after that? She had stents placed before, so she was taken to the catheter lab where basically they look and see how the vessels look. So in patients that have a heart attack that looks like it looks like a full-on heart attack, the more time you spend trying to work them up, the longer it takes to treat, you're basically just allowing for more heart muscle to die. And so so we have to rush them to the catheter lab. And so in the cath lab, they put a cath into one of the veins, snake it up to the heart, and look at the actual vessels of the heart where they can and inject some dye. And so in that dye, they'll see where the narrowing is, and they can put a stent in and open that back up. Does that make sense? Okay.
Yeah.
And so the faster you do that, the more heart tissue you can Okay, so Dr. Pereira, if you have, if this were a STEMI, and let's say, so if you were to repeat the troponin, what would it look like?
So if it were a heart issue, then the troponin would be higher. So
Okay.
it would indicate more heart damage.
Okay. And so if it were, let's say it goes from 0.07 to 0.09 in a span of 3 hours, what would that mean?
I would say that it wouldn't be so severe, be necessarily a heart attack. So maybe, is it angina? Am I pronouncing that right?
Angina, yeah. So it probably wouldn't be angina just because of her clinical picture. But you're right that it's probably not a heart attack. She has kidney disease, and so the troponin is actually cleared by the kidney. And so if it goes up like a mild amount, what we would typically do is just repeat it again, make sure it doesn't go up even higher. But if it goes from 0.07 to like 6.0, that's definitely a heart attack. You need to get them to the lab. So somebody in YouTube is saying that the troponin's high, so it would indicate an MI, and it's because the levels she's at is just 0.07, and her clinical history does not sound like a heart attack. Most likely, it's not a heart attack. And so you can't focus on just the lab. You have to look at the whole clinical picture. Okay. So I think we're running out of time, but the last thing we're going to talk about is Dr. Tran, the X-ray. Can you tell me what you saw in the X-ray? Dr. Sabella, then. Can you tell me what you saw in the X-ray? Dr. Jocelyn?
Hi, sorry, Dr. Sabella here.
Okay.
I recognized some cloudiness and in the right lung, and I was thinking maybe that could be due to infection of the pleural cavity, maybe, and maybe some liquid that could be seen. I'm not sure.
Yeah, and so, so exactly. In the right side of the lung, on that lower side. Last time I tried to pull up the X-ray, my screen went black, so that's why I'm not pulling it up here. But on the lower portion of the right side, you see this white kind of haziness there. And so if you've never read a chest X-ray before, the way to read them, there's a whole process to it, and we'll go over that. But the easy way to do it is look for symmetry. So if on the left side, everything looks clear, and on the right side you have this haziness, well, then there's something there. And in all honesty, you just have to be able to pick out the abnormal. And so looking for symmetries is probably the easiest way now for you guys at your level to do that. So it looks like kind of like a denser whitish area on the right lower side. So what do you think that is?
I'm not sure. Maybe pneumonia, just given the cloudiness.
Yeah, it would be most likely a pneumonia. And so with the pneumonia, you typically have to see it on X-ray, and this one we do. If it were a viral pneumonia instead of a bacterial pneumonia, it would be more hazy and it wouldn't be like this straightforward white. Okay, so so this was a pneumonia. I think somebody asked how was her C-section history relevant? It wasn't. It's just part of the history. So is the cloudiness fluid? It can be fluid. More likely it's the infection itself. So kind of like the pus and the infection. So and I'm just going through some of the comments here. Would it be community acquired or aspiration? So, Dr. Kim, do you want to try to answer that? If it would be community acquired versus aspiration? Dr. Tima, do you want to try to take a stab at that?
I'm not sure.
Okay, so a community-acquired pneumonia is basically just a pneumonia that you get outside of the hospital in the community, right? A aspiration pneumonia is when you accidentally swallow something and it goes down the wrong pipe, so it goes into the lungs. And so if you're eating and that food makes its way to the lungs, well, now you've introduced bacteria from your mouth into your lungs. And so in patients with dementia, aspiration events are what are common, and it depends on how severe the dementia is. And in severe dementia, a lot of times you will pass away from some type of infection. A lot of times it's from a pneumonia. So Dr. Brown is asking if there's any anatomical or biological difference between the two kinds of pneumonia, and there is. It's all dependent on the type of bacteria you're going to be treating. And so with an aspiration pneumonia, you're going to have to cover the bacteria that's found in your mouth, versus a community-acquired pneumonia. It's more so about the normal causes of pneumonia. So you can treat that with just, honestly, if it's strep pneumo with amoxicillin, you should be okay.
But could you tell, like, on like an X-ray or like maybe some sort of test, whether like just by looking at it face value?
Yeah, that's a great question. So with an aspiration pneumonia, a lot of times you aspirate when you're laying down. And so looking at the anatomy, you will see it will happen more so on, if I remember right, it's on the right side in the lower lung levels. And so just because of how gravity works and how the food is gonna, or food or water, whatever, is gonna go down. And so you'll see it mostly, you can see it mostly on that side. But I mean, it's all dependent on where you were positioned when you aspirated. So, but that's a very good point. Okay, so I have to start the next class soon. Were there any last minute questions that you guys have? Sorry if I didn't get to everybody.
One question I did have was from her tests and stuff. You can see that her lungs have most of the issues, but the heart only has tachycardic. So could you like immediately kind of assume that pericarditis is out of the question?
Yes. Yeah. So I think you can rule out pericarditis more so based off the physical exam and how her symptoms sound. So on the physical exam, you don't hear the friction rub, you don't have that positional chest pain, and the history is not. The history actually can kind of be pericarditis because she had that viral infection before the onset of her symptoms. So yeah, it can definitely be confusing, but if you were very worried, and I think in this case, the people that admitted her might have been worried, so they got a echo, which didn't show anything, and on an echocardiogram, you'll see a thickening of the pericardium. So yeah. Dr. Girius is asking, so why are the troponin levels elevated if this is pneumonia? So if they were elevated because of demand ischemia. So her heart is working harder because she has this infection, and this infection is causing system-wide inflammation. And so as her infection's getting worse and her heart's working harder, there's less blood flow to the heart, and she has a history of coronary artery disease to begin with. And so those vessels are narrowed at baseline, and so when you add another insult and add another kind of I guess you add another insult to that system where she's not getting enough blood flow to that part of the heart, you're going to have a little bit of damage to the heart cells, and that can cause a slight elevated troponin, but it's not actually a actual myocardial infarction, because all you need to do really is to give fluids and increase that volume that you're using to perfuse your organs, and that'll correct itself. I'm sorry if that wasn't exactly clear. So I thought we would rule out ischemia because it's not affecting the whole chest, just the right side. People can have right-sided chest pain and have an MI. So yeah. So the white blood cell count does relate to the pneumonia. It's your body's way of fighting the infection. Okay. So if you guys have any more questions, put them in the classroom stream and I'll answer them. I hope this was somewhat educational, and if you have any feedback for the format, let me know, okay?
Thank you.
No problem.
Thank you.
You guys have a good day.
Thank you.
Thank you.
Thank you.